Good afternoon and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Lauren Duran, BBRF's Vice President of Communications, Marketing, and Public Relations. I'm standing in for Dr. Borenstein today since he is hosting a different event scheduled at this time. Today, Dr. Ryan Van Lieshout will present changes in infant emotion regulation following maternal treatment for postpartum depression. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of 184 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has such great impact is because we do not limit our focus to one illness or condition. Since 1987, the foundation has awarded more than $440 million to fund more than 6,400 research grants around the world and across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, PTSD, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Ryan Van Lieshout. Dr. Van Lieshout is an associate professor in the Department of Psychiatry and Behavioral Neurosciences, the Albert Einstein Irving Zucker Chair in Neuroscience, and the Canada Research Chair in Perinatal Mental Health at McMaster University. He was a 2015 BBRF Young Investigator. Our webinar will begin with Dr. Van Lieshout's presentation, which will then be followed by a Q&A. To submit your questions, please use the Questions tab on the control panel on your screen. Please feel free to submit your questions at any time. Following the presentation, I will ask as many questions as possible in the time allotted. And now I'm pleased to introduce Dr. Van Lieshout.
Thank you very much, Lauren. It's an honor to be this week's Brain and Behavior Foundation Meet the Scientist webinar speaker. My name is Dr. Ryan Van Lieshout. I'm a perinatal psychiatrist, as Lauren mentioned, in the Department of Psychiatry and Behavioral Neurosciences at McMaster University in Hamilton, Ontario, Canada. My research is focused on trying to develop and test interventions aimed at increasing access to treatment for mothers with postpartum depression and/or anxiety. Another thrust of my research is examining how these treatments affect infant brain development in ways that affect their risk for psychopathology later in life. Both of these research aims are attempts to try to disrupt the intergenerational transmission of psychopathology from parents to their offspring. When people ask me why I became a perinatal psychiatrist, I joke with them that I actually got into this because I'm a failed child psychiatrist. And while I never practiced child psychiatry independently, I did do a part of a residency in child psychiatry. And the reason I got into perinatal psychiatry is because when I was doing work with all of those wonderful children and their families, we would often sort of try to help the children as best we could. But whenever we asked the families to try to help out, sometimes they had limitations in what they were able to help with, and I found that very frustrating. So I moved over to working with pregnant people, women, mothers, and birthing parents, because I get to work with individuals who all come because they want to be the best parents they can be, and I can work treating them. And I'm hopeful that the work that we do clinically has benefits for their infants as well. And that's where today's talk comes in. Today we're going to talk about, or I'm going to talk about, a study that we did with the generous funding of the Brain Behavior Research Foundation, where we examined changes in infant emotion regulatory capacity following treatment of postpartum depression in the mothers. So throughout today's talk, I'll use the term mothers, but I mean that to imply mothers and birthing parents, but all of the individuals in the studies that we'll talk about identified as mothers, so I'll use that term today. So first I'd like to talk to you about postpartum depression, and particularly its effects on infant emotion regulation, and why we think that's such an important topic. Then we're going to talk about two studies that our Brain and Behavior Research Foundation's Young Investigator Grant funded. The first, we're going to look at how treating maternal postpartum depression affected infant emotion regulation. Then I'm going to take a little foray into some replications of those results that we did. And in a second study, I'm going to discuss with you our look at some of the mechanisms. We weren't sure why treating maternal postpartum depression helped infant emotion regulatory capacity, so we did a second study where we looked more closely at the mother-infant dyad, and I'll share the results of those with you today, and then talk about what we're doing now to try to extend these findings that all started with the BBRF. So postpartum depression affects a huge number of people. About 8% of mothers in the postpartum period will experience a full-blown major depressive episode. But as many as 20 to 30% of mothers and birthing parents will experience elevated levels of symptoms of depression. Why this is important is because when we look at the outcomes of individuals with postpartum depression, their parenting outcomes in their offspring and so forth, what we see is that sometimes their parenting and offspring outcomes do not differ than those mothers who might be just above the diagnostic threshold for a major depressive episode. So there's a large number of these individuals. They and their offspring may be at similar risks, and these people are often not eligible for clinical services because they don't exceed clinical thresholds. And so there's a really large number of individuals that are potentially at risk. Postpartum depression is also an extremely costly illness, with costs of over $100,000, $100,000 US per case of postpartum depression over the lifespan. And because I'm Canadian, this is where we usually insert a joke about exchange rate. So $100,000 US might actually be worth $500,000 Canadian right now. I'm exaggerating, but you get the point. The key thing about the research that we're doing is that we think that up to 2/3 of this $100,000 associated with each case of postpartum depression are actually due to difficulties in the offspring of these pregnancies and of these deliveries. So what is the impact that postpartum depression can have on offspring? Well, the infants born to mothers with postpartum depression are at increased risk of cognitive and school problems, emotional problems, and behavioral problems. In fact, one study suggests that children born to mothers with postpartum depression are 5 times more likely to develop behavioral problems. And as we move later in the lifespan, they may be at 4 times the risk of developing major depressive disorder when they are in adolescence or adulthood. So we know that postpartum depression can have a profound impact on mothers. It can also have a big effect on their offspring. And one of the things that is affected by postpartum depression is something called infant emotion regulation. We've been interested in infant emotion regulation for a number of reasons. But let's talk about what it is first. Infant ER is the ability to modify emotions in the service of future goals. And we know that even the youngest infants are able to do this, albeit with a lot of help from their mothers. So infant emotion regulation is not only associated with postpartum depression, but as I'll show you in a slide or two, it's also associated with those deleterious outcomes associated with postpartum depression that I just discussed. So emotion regulation is involved in the development of emotional problems and involved in the development of behavioral problems. And so in our group, we've been intrigued with the idea that emotion regulatory problems may actually be a mediator, that is the pathway through which postpartum depression affects infants and puts them at increased risk for emotional and behavioral problems. Another reason we're so interested in this construct is that emotion regulation can be reliably measured in pre-verbal infants. So of course we can't ask infants if they're having problems regulating their emotions because they're pre-verbal, but we can use a number of different techniques to triangulate how they're regulating emotion. And the gold standard of assessing emotion regulation in infants is by using a combination of reports by their parents, observational measures where we might have the infant and or mother or their caregiver engage in a task, which we then observe and score, and also using a number of different physiological measures, which are thought to index emotion regulatory capacity. Another reason we're so interested in emotion regulation is that early problems in infancy and early childhood with emotion regulation are associated with a 3 times higher risk of school failure, substance dependence, and income below the poverty line. And problems with emotion regulatory capacity are also involved in the development, in the etiology and symptomatology of almost all forms of psychiatric illness. So the question then for us has been, well, how does postpartum depression affect infant emotion regulation? Well, early in life, infants' prefrontal cortices, one of the brain regions that helps with emotion regulation, is not completely developed. And so what happens early in life is that primary caregivers, usually mothers and infants, form a dyadic regulatory system to help infants regulate their emotions. This usually is kicked off by the infants signaling their mothers, usually by crying or some other signs of distress. And then the mother's attempting to provide support or to soothe or to help provide regulatory support to the infant. Unfortunately, mothers with postpartum depression have a harder time identifying infant signals and a harder time responding to them. We know that individuals with postpartum depression experience more anxiety in response to infant expressions of distress. They react differently than healthy control mothers to this distress and exhibit fewer caregiving behaviors overall. But to date, it has not been clear if we can change those maternal behaviors by treating the mothers alone. In fact, there are surprisingly few studies that have examined the impact of treating individuals with postpartum depression on any outcome in their offspring. Of the studies that have been done and looked at whether treating mothers alone can help infants in terms of their cognitive, emotional, and behavioral development, some studies suggest that treating the mothers can help, while others have said that it may not make a difference. Of particular interest to us is that just 2 previous studies had examined the impact of treating postpartum depression on infant emotion regulation, and both of these studies used maternal reports alone. And while mothers are wonderful informants, of course, on their infants and their regulation, some people have been concerned that when mothers are the only informants that are rating infant emotion regulatory capacity, there's a possibility that the mother's improved mood is what's getting reflected in the reports rather than infant emotion regulation alone. So given the importance of emotion regulation in infants, the fact that very little is known about it, and we're not sure if treatment can help improve it, we set out to engage. We set out to do 2 studies funded by BBRF to look at this. One, examining the direct effects of postpartum depression on the infant and their emotion regulation, and a second that examined how treating the moms affected the mother-infant regulation system, this dyadic regulation system that mediates emotion regulation in infants. And so the study that we did consisted of 40 mothers with postpartum depression. So these were individuals who had current major depressive disorder. They were all patients in an outpatient clinic, an outpatient perinatal psychiatric clinic out of McMaster University. And they had infants that were less than 12 months old. They could have other disorders, they could have other problems, but they all had to have current major depressive disorder. We then compared these individuals to 40 healthy control mothers who themselves were free of mental health problems, but we matched them in terms of their infant's age, infant sex, and family socioeconomic status. So the reason that we chose a healthy control group as our comparator was several-fold. One, we knew that we could recruit this group, and 2, we wanted to make sure that the effects that we saw were due to depression and not family socioeconomic status or something like that. And 3, we wanted to see if treating the mothers with postpartum depression could result in could result in outcomes that were similar to the healthy control group. Could we help normalize some of these outcomes? So the mothers in the postpartum depression group received 9 weeks of group cognitive behavioral therapy. So pretty standard CBT. I'll describe it below. These sessions, so there were 9 weekly sessions. They were 2 hours in length. They were delivered by a perinatal psychiatrist and a social worker or a nurse, depending on who was available for that 9-week session. And the first hour of each session focused on teaching core cognitive behavioral therapy, or CBT skills, things like cognitive restructuring, behavioral activation, and so forth. And in the second hour, participants and the facilitators, the therapists, co-led a discussion topic, and we had a discussion around topics that were thought to be important to moms with postpartum depression, things like supports, transition, sleep, and so forth. So we measured mothers and their infants at 2 time points. The first time point, visit 1, was before the mothers with postpartum depression got treatment. And visit 2 was 9 to 10 weeks later, after they had completed the 9-week group. The healthy control group, that's the orange group, they were just tested at baseline and then 9 to 10 weeks later. Throughout the slides that I will present, the postpartum depressed group is in blue. So in terms of measures, in infants we used a multi-method approach of assessing emotion regulation that used parent reports, observational, and physiological measures. So our parent reports involved mothers and fathers when they were present, reporting on infant temperament on the infant behavior questionnaire revised. We looked particularly at the orienting and regulation subscale. We used the face-to-face still face task, which I'll describe in a few minutes. And our physiological measures, we measured frontal alpha asymmetry using EEG, electroencephalography. And frontal alpha asymmetry is calculated by subtracting the alpha power in the left frontal hemisphere from the right. And the important thing for interpretation, and I'll go over this several times because it can be complicated, is that greater resting relative right frontal activity reflects a tendency to display more withdrawal-related behaviors and a predisposition to experiencing negative emotions, while greater left frontal asymmetry is more reflective of positive emotionality. We used ECG, or electrocardiography, to measure high-frequency heart rate variability. And higher values of high-frequency heart rate variability are reflective of more adaptive control and flexibility of the nervous system to handle stress and to help regulate the infant. In the mothers, we measured just their demographic characteristics. We took some clinical measures on the mothers in the postpartum depressed group, and we also measured their physiology as well. So in terms of our sample, briefly, the infants were about 5.5 months of age when they started the study, and about 8 months of age when they were finished after visit 2. About half were male. They were all born at term and had a birth weight of around 3,300 grams, which is about the average for infants in the province of Ontario. Family household income in the participants was around the mean for the province, and mums were about 33 years old when they entered the study. About 3/4 of them had graduated high school. In terms of the depressed group, the mean, so there's a scale we use called the Edinburgh Postnatal Depression Scale. It's to measure postpartum depression. It's scored out of 10 items. There's a maximum score of 30. The participants in the study, when it started, had a score of about 15, which corresponds to about a moderate level of depression. The average score in the control group was 4, suggesting they had few to no symptoms at all. Another important thing to know is that the scores in the treatment group went from 15 to below 10, suggesting that their depression had improved significantly. So as we look at the results of this study, when we look at the impact of treating maternal postpartum depression on infant emotion regulation, I'm going to take you right to the left side of the figure first. So the blue bars are the infants of the mothers with postpartum depression. And what you see here on the extreme left on the y-axis is that right frontal asymmetric activity corresponds with poor emotion regulation. And you can see that at visit 1, at baseline, the infants of the mothers with postpartum depression had poorer emotion regulation than the infants of the healthy control mothers. So that's good. That's not good news for the infants, but this suggests that our control group is functioning the way that we want. What we see with the blue bar after treatment by visit 2 is that it flips from right frontal asymmetry to left frontal asymmetry. And this is suggestive of better emotion regulatory capacity. And this improvement in frontal alpha asymmetry was statistically significant, and it was of a medium effect size. And at visit 2, there was no difference between the infants of postpartum depressed mothers and the infants of the healthy controls. When we go over to high frequency heart rate variability, again, the higher we go on the scale, the better the emotion regulation. And you'll see that the blue bar is lower than the orange one, suggesting that the infants of mothers with postpartum depression had more difficulty regulating emotions at baseline at visit 1. By visit 2, there was a significant increase in high frequency heart rate variability in the infants of postpartum depression mothers after just 9 weeks of cognitive behavioral therapy. And they were not different from the healthy control mothers, and this was also a medium effect size change. So we've got 2 physiological indices of emotion regulatory capacity in infants, and it suggests that treating their mothers can actually improve their ability to regulate themselves. We also, when we looked at the maternal and paternal ratings of regulation behaviors on that questionnaire measure, we saw that it also increased in the postpartum depressed group from visit 1 to visit 2. The effect sizes were a bit smaller, but they confirmed the results that we found with the physiology. And so we were really intrigued by these results, and we were excited about the possibility that we might be able to improve infant emotion regulatory capacity, and particularly its physiological indices, with just 9 weeks of CBT. But because this is the only study that had been done to date, and it was based on a comparison to healthy controls over time, we subsequently did 2 small randomized control trials where so these are 2 different studies, separate studies, where we had all depressed mothers. So these are all mothers who had an Edinburgh postnatal depression scale score of 10 or more, which is suggestive of possible depression. These were all mothers living in the community. They weren't a hospital sample, because we were trying to see if this improvement could happen in people who had less severe depression. And we took these mothers and we randomized them into either receiving the same 9-week group CBT intervention or just getting treatment as usual. So in the treatment group, what would happen is we would measure mums before and just after the 9 weeks of CBT, the same intervention as we delivered in the BBRF-funded study. And this time the control group were also mothers with postpartum depression, but they did not get treatment over that time period. So there were 2 separate studies that we did. The first was delivered by a group of mothers who themselves had recovered from postpartum depression in the past. We call them recovered peers. And a separate study, public health nurses who'd been screening moms for postpartum depression anyways were trained to deliver the same 9-week intervention we used in the BBRF study, and it's the same intervention as the peers delivered as well. So same theme here. On the left, we have frontal alpha asymmetry. Higher is better. And on the right, we have high frequency heart rate variability. So if we look at the bar graph on the left, the infants of mothers in the treatment group and the control group, they didn't differ at baseline, even though the blue line looks like it's further down below the 0. It wasn't different, statistically significantly different. But what we saw with the treatment group is that when the mothers with postpartum depression got treatment right away, their infants had shifted to more left frontal asymmetry, better emotion regulation after just 9 weeks again. What we saw in the postpartum depressed mums who didn't get treatment is that their infants' frontal alpha asymmetry worsened with continued exposure to postpartum depression. With our second physiological measure, high frequency heart rate variability, again, we see that the depressed treatment group, that's the blue group, they didn't differ from the untreated depressed group at baseline. But after they got 9 weeks of group CBT, their high frequency heart rate variability increased significantly and was higher than the postpartum depressed group who didn't receive the treatment. So we have converging data with our BBRF data suggesting that just 2 months of CBT can improve emotion regulatory capacity in infants. So in our a slightly larger randomized control trial with public health nurses delivering the CBT, we actually didn't see improvements in frontal alpha asymmetry, and that may relate to things relating to the mother's socioeconomic status and so forth. But we did see that the treatment group, in terms of high frequency heart rate variability, the treatment group, the infants in the treatment group, improved significantly in terms of their high frequency heart rate variability, that index of emotion regulatory capacity, while the mothers that were waiting to get treatment or that didn't get treatment did not improve. And so those last two slides are unpublished data, but are under review. And what they suggest is that our BBRF findings might actually be true, because we were able to show across different study designs with different therapists and different severity of depression that we can improve infant emotion regulation. When we explored the data in all three studies, we took a close look to see why. What was happening with the mothers? What was happening with the mothers that contributed to their infants developing better emotion regulatory capacity? So we looked at things like maternal depression and maternal anxiety and so forth, and we found that though there weren't high correlations between improvements in maternal symptoms and infant emotion regulatory capacity. So we were intrigued, and my very bright then PhD student, John Kraskowski, proposed a second study that we then did to try to understand what was going on with the mothers and the infants that might have contributed to this improvement. So as I mentioned earlier in the presentation, postpartum depression can disrupt the process of mothers providing the emotional scaffolding needed to regulate their infants during moments of distress. But it's still not clear what mechanisms underlie this sort of transmission of regulatory support. Knowing how this happens is important to understanding how moms with postpartum depression shape infant emotion regulatory capacity, and subsequently how psychiatric risk is transmitted to offspring. Since the prefrontal cortex in infants develops over time, distressed infants have limited self-regulatory capacity in the first year of life, and so they need their mothers, they need maternal regulatory influence. And the mutual regulation model posits that the mothers and infants form a dyadic regulatory system whereby mothers provide regulatory support. Postpartum depression, as we discussed earlier, disrupts this dyadic regulatory system as moms have a harder time detecting infant signals and show fewer caregiving behaviors in response to distress. So what we wanted to do was we wanted to see how mothers might be transmitting this regulatory information to their infants to help them. And we wanted to see if this was different in healthy control mothers and our depressed mothers. And we also wanted to check in on whether treating the mothers with postpartum depression could impact these processes. And so we did this in the same sample, but we used something called the face-to-face still face task, so that we could try to elicit infant distress and see how the mothers tried to regulate it. So in the face-to-face still face task, it consists of 3 phases, and each of these phases lasts 2 minutes. In the first phase, called the play phase, mothers and infants are instructed to play as they normally would, but the infant is in a high chair while they play. In the second phase, called the still face phase, the mothers are instructed to go completely still-faced for 2 minutes, or go poker-faced for 2 minutes, and not to respond to their infant's changes or expressions of distress. Not surprisingly, and you'll see in the slide there, that infants can get quite distressed in response to this, because in healthy dyads, they're used to their mothers responding in a contingent way. Then after the infant is distressed during the still face task, there's a reunion phase where the mothers are allowed to respond to their infants in any way that they like. And it's during this phase that we examined how mothers and infants' emotion regulation shifted. So in this second study, we used the same 40 postpartum depressed dyads and healthy control dyads. And what we measured over time is we measured each member of the dyad's high frequency heart rate variability. High frequency heart rate variability is a measure of parasympathetic nervous system function, and as I mentioned before, higher levels are suggestive of better emotion regulation. And we examined this during the reunion phase when the mothers were trying to regulate their infants. And what we did is we looked to see if the mother's regulation influenced the infant's regulation 1 second later. So we measured mother's high frequency heart rate variability at one moment and then the infant's 1 second later, or we looked at it with mothers in one moment and the infant's 1 second later to see if the mother's change in emotion regulation was affecting the infants. And we also looked at vice versa, if the infants were influencing the mother. Really what we were looking at is this regulatory dance that happens. If you've seen, mothers who are strong in that role interacting with their infants, and when the infants are distressed, it's like a dance where the mother leads and regulates the infant, and the infant then helps to regulate itself. And so that's really what we were looking at it with some fancy statistical and physiological measures. So starting on the left of the diagram, at study visit 1, at baseline, what we found is that mothers would engage their regulatory systems first, and then infants would regulate theirs in response. So this is probably indicative of the healthy dance, where mothers are regulating first and helping their infants to regulate themselves. Whereas in the depressed dyads that are denoted in blue, what was happening is the infants were having to regulate first, and then the mothers regulated afterwards. So obviously this wasn't ideal. What we saw after the depressed mothers were treated with 9 weeks of CBT is that they took over lead of the dance, and what we saw is that mothers would regulate first and then infants would follow. Essentially the pattern that healthy control infants and mothers had demonstrated at study visit 1 and at study visit 2. And so what we see here is that we think that high frequency heart rate variability is a mechanism through which mothers can actively regulate infant distress in real time. And what we're even more excited about is that treating postpartum depression may enable mothers to better respond to infant cues relating to their distress and to providing support. Now, we're not entirely sure what underlies this, and this is something we're going to investigate further, but it might be due to improvements in sort of top-down prefrontal cortex sort of functioning that enable mothers to better detect and adapt to maternal cues. And so we were very excited to find that treating maternal postpartum depression with a brief, cost-effective psychotherapeutic treatment that's easily scalable and since it's a talking treatment is preferred by many mothers, that it was associated with improvements in infant emotion regulation, as well as improvements in dyadic regulation under stress in mothers and infants. And we were excited that these two things improved to levels that were quite similar to healthy control dyads over the 9 weeks of treatment. Talking about the first BBRF-funded study, the one where we looked at whether treating maternal postpartum depression could improve or optimize infant emotion regulation, the improvements were of medium effect size. So they weren't small, so they're sort of bordering on clinically significant at the level of the dyad. And if we looked over a longer period of time, perhaps the effect size would be bigger. Regardless, these findings were consistent with the 2 previous studies that looked at the impact of treating postpartum depression on infants using maternal self-reports. And we were excited that we were able to replicate these BBRF findings in 2 subsequent studies with slightly stronger research designs and using mothers who have depression of varying severity and with varying therapists. So we're very excited about the fact that we were able to train mothers who'd recovered from postpartum depression to provide treatment, and also public health nurses, because they're a lot, let's be honest, they're a lot cheaper than psychiatrists like me. So we're excited about the potential scalability of this sort of thing. How these changes happened, we're not entirely sure. We were a bit surprised that it wasn't due to improvements in symptoms of postpartum depression alone, or another scale of mother-infant bonding that we used. So we're not exactly sure. We weren't exactly sure what was going on. We thought it might be, or Dr. Kreskowski thought it might be, due to improvements in the quality of the maternal signals that the moms send, or the way that they respond. And that's why we did the second study, which showed that healthy control mothers kind of lead that regulatory dance when their infants are distressed and help them regulate their emotions, whereas before treatment, mothers with postpartum depression are more influenced by their infants. That is, they follow the leads of their infants, rather than leading themselves. But as I mentioned, after we treated the mothers with postpartum depression, that pattern reversed and normalized, so that the mothers were transmitting regulatory inputs to their infants in the same ways that healthy control mothers would. So we were excited that this mechanism was malleable with treatment. Of course, there are limitations to the study. That the samples were relatively small. We had to stop this work in Canada. We did essentially no infant. We were permitted to do no infant testing during the COVID lockdowns, so we weren't able to collect bigger samples. The follow-up duration was just 2 months, and the BBRF study used an observational study design, but we did replicate it in stronger study designs later. We're still not sure exactly what's changing or why. We're not sure what's going on in the brain. But the ultimate goal of this work is to try to identify those aspects of treatment that are leading to improvements, not only clinically in the mothers, but in the brains and emotional regulatory capacity of the infants, so that we can develop optimal treatments that can improve outcomes for both members of the dyad. So what are we doing next? Well, the Canadian Institutes of Health Research, which is the much smaller but Canadian version of NIH, I guess, has funded us to do a randomized control trial of 156 mothers, where we're going to treat them with group cognitive behavioral therapy, and we're going to look a bit more closely at what's going on. We're going to look at different brain regions and neurocircuits using functional near-infrared spectroscopy, and we're going to look more carefully at the mechanisms that might be underlying these changes. We're going to look at maternal regulatory parenting and mood variability, and take a closer look at maternal emotion regulation to see if that's influencing things. And we're also going to look at, one of the fun things about functional near-infrared spectroscopy is that we can record from mothers and infants at the same time, and we can not only observe them, but record their physiology, in sync, and see if there are any clues there to what's going on, so that we can try, ideally, to disrupt the intergenerational transmission of psychiatric risk. And so I wanted to say that those are all my slides, and I wanted to say a big thank you to everyone who's in attendance today. Thank you for your attention, and to the Brain and Behavior Research Foundation for awarding me with a new investigator grant so many years ago. Also, thanks to the Canadian Institutes of Health Research, the Canada Research Chairs Program, and the Dyad Foundation, a philanthropic foundation in Canada that is starting to support psychiatric research as well. And then, of course, Dr. John Kreskowski, who was then my PhD student, is now a faculty member at Brock University, drove a lot of these studies. Dr. Bahar Amani, another former graduate of our lab, who ran the randomized control trials. Ms. Haley Layton, our research coordinator, and Niagara Region Public Health, the partner for the Public Health Nurse Study, and Kids Can Fly, a not-for-profit organization in Canada supporting maternal and child wellness. So thank you very much.
Thank you, Dr. Van Lieshout. Thanks for an excellent presentation and very informative. The research that you are doing is really quite exciting, and we do have a couple of questions. So first, Are there any symptoms of postpartum depression during pregnancy? And are there currently any screenings for vulnerability to the illness?
That's a very important question. And years ago in the Diagnostic and Statistical Manual, that's our diagnostic cookbook for psychiatric disorders, they identified postpartum depression as a specifier of major depressive episodes. But in recognition of the fact that about 50% of episodes of postpartum depression actually emerge in pregnancy, now they refer to it as a major depressive episode of peripartum onset, in recognition of the fact that symptoms are often present during pregnancy. And in fact, one of the most potent risk factors for developing a postpartum depressive episode is elevated levels of symptoms during pregnancy. There's a the screening or detection tool that's used the most often, and I think is recommended by the American College of Obstetricians and Gynecologists, is something called the Edinburgh Postnatal Depression Scale, which I referred to earlier. It's a 10-item questionnaire. Items are scored 0 to 3, and it's freely available. You can find it on the internet. Your doctor, nurse, midwife, anyone can administer it. And scores of 10 or more, or 11 or more, depending on the paper that you read, suggest that the individual may be depressed, and that they should go and receive a diagnostic assessment by a physician, psychologist, or anyone else licensed to do that.
And this is just a follow-up just that I was thinking. So if you're showing elevated levels during pregnancy, are OBs, to your knowledge, are OBs or any treating doctors screening for this is this part of common practice now?
Well, it's a good question. It's certainly been recommended that this be the standard of practice. Unfortunately, in Canada, a national organization recommended against screening for postpartum depression and depression during pregnancy, and that's been debated pretty hotly here in this country. But I'm not sure what the uptake is. So in Ontario, we have a couple of questions on our screening measure that are from that are similar to the EPDS, but so it's hard to tell. I mean, people are aware of this. People are aware of it. Professionals are aware of it, but whether they screen in their own practices is their choice. And I'm not sure what the prevalence would be in the United States.
Thanks. Also curious, how early can you tell if an infant has any emotion regulation issues, and is this indicative of postpartum depression with the parent, or can they be completely separate?
So, one of the advantages of using multiple measures to assess emotion regulatory capacity is we get this wonderfully complete picture. The disadvantage of having to use multiple measures is that there's no one measure where we say this child has this infant has this problem or not. So there isn't a screening measure for clinically significant problems. Clinically significant. So there's no clinical measure to do that right now. And then what was your second question, Lauren? Sorry.
I think it was more on if an infant has emotion regulation issues, would this be indicative of perhaps the mother with postpartum depression?
Thank you. Yes, thank you. Sorry about that. Yeah. So problems with emotion regulatory capacity in infants can be due to many different things. Could be a manifestation of some other medical health problem. So it's not specific to postpartum depression, although it is something that can be affected in mothers with postpartum depression. Of course, not all mothers with postpartum depression will have infants with emotion regulatory problems either. It's important I should note that as well. Yeah, good questions. Thank you.
Thank you. And lastly, where do you see your work going in the next 5 to 10 years? What can people look forward to in terms of themselves or a loved one who may have postpartum depression?
It's hard to believe that anyone would be excited about my work other than my mother, and she is very excited about my work. But I think over the next 5 or 10 years, we're going to complete this larger trial that we've looked at, and we're going to collect lots of data. And hopefully we'll be able to identify what the quote active ingredient might be in what's changing with the mothers and helping their infants as well. And then ideally, we would start to adapt the treatments to try to optimize that, because we know these treatments can be effective for mothers, but I think the holy grail would be to identify what aspects of it could help the infants as well. Of course, there are mother-infant psychotherapies that exist that target these things as well, but there's different training, and sometimes the moms are too depressed to do some of those things. So we're really looking forward to trying to figure out what's going on, and then use those findings, one, to optimize the treatments, and two, frankly, to start to advocate for more widespread detection and treatment of this problem. I mean, it's interesting scientifically to us what's going on, and we want to optimize treatments, but we also want to use this to bring to the attention of funders the vital importance of trying to reduce the prevalence of this adverse childhood experience, so that mothers and infants can get the best starts in life possible.
Thank you. Thanks very much. Very interesting. So I am at the end of the question list. So thank you. Once again, I'd like to thank Dr. Van Lieshout for providing us with a very enlightening presentation. And I'd also like to thank everyone on the webinar for joining us. I'm pleased to share that BBRF has received a $1 million challenge match for 2023 from two very generous family foundations that are passionate about our mission. The goal of the match is to accelerate the momentum in brain research as further breakthroughs are still needed. You can participate in this initiative if you are a new BBRF donor, a past donor who has lapsed but made a new donation this year, or if you are a current donor who increases your gift. Your increased amount will be matched. I hope you will consider making a donation to BBRF today. 100% of every dollar donated for research is invested in our research grants. We can do this because our operating expenses are covered by separate foundation grants. This means that when you donate $1 for research, that dollar goes directly to the scientists. To make a gift, please visit bbrfoundation.org or call 1-800-829-8289. Today's webinar has been recorded. If you missed any portion of this presentation or would like to share it, please visit the Events and Webinars page on our website. Please join us again on May 9th at 2 p.m. Eastern when Dr. Nikhil Urs, Assistant Professor of Pharmacology and Therapeutics at the University of Florida, will present how the brain's dopamine circuitry helps regulate cognitive flexibility and reward seeking. Thank you. And remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives.